slow up, no I don't take shit. I got no love for the fakeness. If you wanna play tough and wanna hate this, I'll always show up.
Welcome back to another video on the channel. We're here today. We're gonna go over ABIM dermatology questions. These are the questions created from the most high-yield educational objectives that I created and gotten from MKSAP, UWorld, and all these testing, high-yield testing websites and question banks, and basically having AI analyze them and create certain questions. I've used my own instructions that I've been developing and getting better over the past few months, and especially last month, these instructions are getting way more accurate and better. So the questions test all associations and possibilities that can present with these questions, and I'll show you how one question can be tested in so many ways. And the goal of these sessions is for us to create questions, be able to create our own questions and our own question banks, and basically be able to not drawn out of questions. Because when you're doing it, for example, a internal medicine residency for 3 years, you've been around for doing all these things, you're gonna run out. You can do UWorld. Some people say, oh, do UWorld twice, but how effective is it really to do UWorld twice, where you can and basically remember a lot of questions, so there won't be any actual thinking when you do the same question back again, because you're gonna still recognize the question. So this way, you create your own questions. You can test the subjects that are you're weaker on, and basically be able to have a new source as you go, and questions that come up. All right, so let's go ahead and get started. This is going to be a 28-year-old woman. She presented to the clinic with well-demarcated depigmented patches on her hands and face. She has no significant past medical history, but had noticed progressive skin changes over the past year. She denies any pruritus or scaling. Physical exam reveals sharply demarcated depigmented macules on the perioral region and dorsal hands. Which of the following conditions is she at increased risk of developing? Okay, so basically first, this question wants you to recognize what kind of condition it is, and then it's asking, do you know which a special autoimmune condition is associated with it? So go ahead and pause the video right here, pick your answer, and then we're going to go through the options together. All right. So it's going to be thyroid. Vitiligo is an autoimmune disorder, right? It is in the melanocytes are progressively destroyed. It leads to well-demarcated depigmented patches. It often has an autoimmune association, with the most common comorbidities being autoimmune thyroid disease, such as Hashimoto's thyroiditis and Graves' disease, as well as type 1 diabetes. You really need to memorize vitiligo, thyroid issue, and type 1 diabetes. This group usually happen together. And so the key clues are, it's a young patient. As soon as they tell you about these well-demarcated depigmented macules, there's no pruritus or scaling, so that kind of rules out the inflammatory skin issues and diseases. SLE usually presents with a malar rash and the photosensitive rash. It is not depigmented. Atopic dermatitis is incorrect. That one is another pruritic erythematous kind of a rash presentation, not a depigmentation, and there's no association there. Psoriasis presents with erythematous plaques with silvery scales, not really a depigmentation, and they don't really associate. And this is a cancer, and vitiligo is not associated with any of this BCC, which usually presents with pearly nodules with telangiectasias. Autoimmune thyroid disease is correct. 20% of vitiligo patients develop autoimmune thyroid disease, making it most likely associated condition. When you look at the algorithm, when you see the depigmented macules, you need to think vitiligo, and look for associated autoimmune conditions such as thyroid and type 1 diabetes. Rule out inflammatory other skin conditions. And when you go through the latest guidelines, so patient should be screened for autoimmune thyroid disease, right? So if they have vitiligo, you also screen them for thyroid So you can get the TSH and thyroid antibodies in that case, and also, of course, you're checking them for diabetes if they haven't already diagnosed. Treatment options would be the topical, if you can, if not too spread out and diffuse. Then you also have the calcineurin inhibitors or the UV therapy. And just remember there, the calcineurin inhibitors, they have side effects, and they may test you on certain of these, and just go over your side effects. I'm sure we're going to have this come up in other questions. The key takeaways: vitiligo is autoimmune melanocyte destruction, increased risk of thyroid disease and type 1 diabetes. We're not going to miss any questions related to this. Just imagine how many ways this could have been tested. Just going through this, they could test for the diabetes, they could have the what is the next best step if you have vitiligo, and then the other would be what is the preferred treatment, things like that. So they could ask this and the association in many ways. All right, so let's go to the next question. This is also another high yield question that I've seen so many times. You see these questions even on the internal medicine shelf exams. So this is a 35-year-old woman. She comes to the clinic. She's complaining of increased hair shedding over the past 3 months. She reports no itching or scaling, but states that she has noticed an excessive amount of hair falling out when she showers or brushes her hair. Recently, she's lost 20 pounds following a strict diet and exercise regimen. A physical exam reveals diffuse hair thinning across the scalp, but the hair shafts and scalp appear normal. A hair pull test is performed, and more than 15% of the fibers are extracted. So these are all clicking into the diagnosis, very specific for this diagnosis. Which of the following is the most likely diagnosis? So go ahead and pause the video right here, pick your answer, and I'm going to go through each single option together and to go from there. All right. So, of course, this is the telogen effluvium. I don't know how to, I'm not butcher these names, but man, I've seen this question so many times. Is it common? It is a diffuse, non-inflammatory hair loss. Okay, it's caused by a stressful trigger. Now, a lot of times it could be a weight loss, it could be pregnancy, it could be illness, it could be a psychiatric trauma, and these patients just the hair follicles prematurely shift from the growth phase to the telogen phase. That's why it's called telogen. That means that they basically become very thin because they go prematurely go from the growth phase into that shedding phase. The hair pull test is positive when greater than 10 to 15% of fibers are extracted, which really would confirm the diagnosis. So the answer, this could have been they could have held this back and then say what would be your next best step, and you to diagnose, you say hair pull test. You could do that. So that's another way you could be tested there. So the key clue is that the diffuse hair loss, there's no inflammation and scarring and scaling. There's a recent stressor with weight loss and exercise. The positive hair pull test was really the basically it just hits it on the nail right there. So the androgenic alopecia would be incorrect because this is related to the progressive hair thinning, especially around the temporal and vertex of the scalp that you see in men, and then the widening central part you will see in women. And telogen actually is a generalized kind of hair loss. Alopecia areata, you see this, a lot of questions on this as well. It is demarcated, well demarcated patches of complete hair loss with exclamation point hairs. But the TE is not demarcated like this, and there's no such a thing as exclamation point hair, and also it's diffuse and not patchy. Okay. Tinea capitis is a fungal infection. It causes scaly patches. There's pruritus and broken hairs. And then the trichotillomania, this would be even the epidemiology would probably be different. Maybe a younger patient, you would imagine self-induced hair pulling, then that would have irregular patches with broken hairs of variable length, and those are all very, very high yield things to know about trichotillomania. And telogen, again, this correct answer. It's acute diffuse hair loss triggered by stressors. It's a positive hair pull test, and the algorithm again kind of repeats itself and just says where to focus. Without inflammation, is there a recent stressor? Did they do the hair pull test? These are all important factors for you to think about this, different diagnosis. And if we just went through the options, but usually gradual thinning, vertex, or scalp would be the androgenetic. If you have the itchy, scaly scalp, probably tinea capitis. Patchy hair loss, think about the errata or trichotillomania. And then the diffuse thing with a stressor, you come to our diagnosis of TE. And usually TE is self-limited. It resolves within 6 to 12 months. No specific treatment is required. So again, they could have said, hey, what instead of saying what's the diagnosis, they could have said what would you the best next step in treatment, and you would say no specific treatment is needed. You reassure the patient, address the underlying triggers. Maybe she's exercising, losing weight, make sure she doesn't develop any nutritional deficiencies, make sure she hydrates herself, eats properly, sleeps properly, and things like that. And the key takeaway, just remember, diffuse hair shedding following a stressor with no inflammatory signs on the scalp, this and a positive hair pull test usually is TE and resolves within 6 to 12 months. Okay. If you're enjoying this video, please give me a like and write a comment for me, subscribe, and let me know if you need to you need me to change anything, if you want the format of the videos to change. I really think these are each question, when we do go through like this, we actually tackle many more questions. And when we do this together, you can listen to this anytime, and you just I have put all the videos onto a playlist, so you can basically go through the playlist. And if you were to you're not really a podcast listener, or you don't want to listen to the videos, you can always also go access the notes that I put, the summary notes of each session with the high yield points in there. You can access that on my Patreon channel. All right, thank you so much. Let's move on to the next question. So question 50, this is a question 52, question 3, and last question in this bank. This is a 52-year-old man, okay? He presents with thickened, discolored toenails that have been progressively worsening over the past year. So it's kind of like a chronic thickening and discoloration of toenails. He reports no associated pain or itching. A physical exam reveals a yellowish brittle nails with dystrophic changes. Now, which of the following is the best next step in the management of this patient? A, prescribing the oral terbinafine. B, KOH prep. C, topical antifungal. D, nail biopsy. And then E, advise watchful waiting. So go ahead and pause the video right here, pick your answer, and then we're going to go through each of these options together. All right. So this is of course, a fungal infection, onychomycosis. But the question is saying what is the best next step, or BNS, or you can say NSM. These are next step in management kind of questions, right? So in these cases, right, you want to get the KOH prep of the nail scrapings, just because usually for onychomycosis like this that grows for a year and it's not going away, you have to start oral therapy. So let's go through the pathophysiology. So this is a fungal nail infection, right? It's leading to the white, yellow, or brown kind of discoloration of the nails. It thickens them and it turns them dystrophic. And only 50 to 60% of patients with nail dystrophy actually have onychomycosis. So other conditions need to be considered, like psoriasis, eczema, and lichen planus, right? They can somewhat resemble the discoloration. Okay. Since oral antifungal therapy is going to be long-term to treat these kind of infection, there is a lot of side effects that could be expected, such as the liver issues, hepatotoxicity that can happen with terbinafine, because that's the first line there. So confirmation of the fungal infection with a KOH prep is recommended before initiating treatment. So very important to actually get the KOH prep. Now I'll tell you, in practice, a lot of places that I've worked at, unfortunately, they don't have the KOH prep, and they may empirically in practice start people on the treatment. So I tell you that in practice it may not happen like that. That's my experience, but the best way, is to get the KOH prep for the boards every day. Okay, anytime you see this question. So key clues. You see the discolored thickened nails, the chronic nature, and then again these kind of fungal infections do not cause pain or pruritus or any sort of systemic symptoms. You prescribe the oral terbinafine, that would be wrong because you need to confirm before you do that. And then the KOH prep is the best way because it's simple, inexpensive, and a reliable test to detect these fungal elements in the nail. And there are other alternative confirmatory tests like a fungal culture or histopathology, but I'm thinking these probably would take longer. And starting the topical antifungal therapy like efinaconazole is incorrect. These kind of infections will be usually they've been going on for long, and if there are multiple toes involved, the topical is not going to be enough. It could maybe help with milder versions where maybe a little bit of the distal nail involvement and one of the toes, yeah, but something like this with worsening and over a year with dystrophic nail changes, you do suspect that this is a more advanced case requiring a systemic therapy. Nail biopsy, so this would be great. This is usually rarely needed because that if you were thinking this was related to malignancy or had a unusual presentation, that you would do that. The last one was watchful fading. That would be incorrect because onychomycosis is progressive and actually can lead to secondary bacterial infections and nail deformities. Remember that one of the most common causes of food infection in diabetic patients is an underlying fungal infection that causes the skin basically to be more prone to infections. Remember that. That's a very, very important point to remember. And the risk factors basically in diabetic food would be there. Another question that you can tie into this one. But remember that these onychomycosis is progressive and it can lead to secondary bacterial infections and nail deformities. Okay, so the algorithm here for clinical decision making, you see someone with nail discoloration and thickening. Consider as one of your top differentials this being an onychomycosis. Rule out the mimickers. Do you think this is eczema, psoriasis, or lichen planus? Are there any qualities that may point you in that direction? Confirm that it is a fungal. You can get a KOH prep, and if it's present, then you can consider the oral terbinafine or itraconazole. But the first one is oral terbinafine, and just remember, we don't just give it, you need to confirm it. And usually the most effective treatment is about 6 to 12 weeks of basically very long term. That's how many months is that? 4 weeks, that would be, let's say, 3 months. Yeah, so that's a lot to put someone on an antifungal, and that's where the hepatotoxicity would should be taken seriously. The conazole or efinaconazole, the topical, only for mild cases. Do not use that in one that is multiple toes and severe with dystrophic nails. Okay. And the final answer, again, obtain the KOH prep. So thank you guys so much for being here. Thanks you so much for your like, subscribe. Please write me comments, engage with the post, share this with your friends. If you're enjoying these, you can access the notes on my Patreon. I really appreciate any comments. And we're going to continue to keep posting these. I'm going to try to use my instructions in other AI engines to see if we can create better outcomes, see which ones do better. That way we know which AI tool would be best to create these. But so far that I've tried a number, personally, I have liked GPT a lot. So that's why we're doing these first episodes with GPT. Once you get used to the way they break things down, we can now start to move on towards testing maybe DeepSeek. Maybe we can test Claude 3.7. I mean, you name it. I even want to try the Gemini and Grok 3. Those are all interesting ways to see how they answer questions and how they analyze them. But I'll tell you that if you don't use the educational objectives and the guidelines in therapy and putting them into the GPT and your instructions, a lot of times they may actually make mistakes because they're not made really to answer board questions, and board questions are written in certain ways. That's very important to have your UWorld MKSAP, those board resources always available and practice. And once you've done those once, you can probably use the educational objectives specifically on the questions that you get wrong to test yourself over and over again in different aspects of the same question. So thank you so much for guys for being here. I'll see you on the next one.
If you wanna play tough and wanna hate this, I'll always show up.